Okay, this is a patient coming in with dizziness, lightheadedness, nausea and vomiting, diarrhea, and abdominal pain. There's the GFR is 29, so a non-contrast CT was performed instead of post-contrast. And this is what that looks like. So let me make this a little bit bigger. Hopefully this is okay. All right, so what I saw was kind of stuff in the liver. And here's the axial. No priors. Okay, so I'm going to go back to the liver. So I saw gas, portovenous gas right there. And then there's some here too. And the caudate. And then, but bowel looks great. Bowel looks great. Patients in their 80s, and I didn't see any free fluid. The bowel is not dilated. And I mean, there's some athero, but not a lot of calcification. So, but you know, portal venous gas, I was like, oh no, like,
Hey, is someone's
what's
like, is that bowel definitely okay in the left lower small bowel?
left lower small bowel, like here, like here,
Go up.
up, okay.
Yeah, okay, never mind. It doesn't look like it.
What's the lactate level? Lactate is fine.
Lactate. So I mentioned this. I said get lactate and just go for a because you got to rule out ischemia, right? Mesenteric ischemia.
Yeah.
So despite the low the GFR of 29, that's baseline. I was like, fine, just give contrast. It's okay. And so we did end up getting a CTA, and it was still negative. Um, so this is what the CTA looked like. The gas, there's less gas.
Oh, are you trying to show some occult cancer because and causing some gas-forming organism infection?
N no, but wait, does occult, I didn't even mention or think about occult cancer. Wait, does it like, can you see this with occult cancer?
Yes, occult cancer, if when they get infected by two bacteria, Streptococcus bovis and Clostridium perfringens, it causes like it produces first with septicemia and emphysematous infection, and that when you find these organisms, then you go back and hunt for occult cancer.
Okay, well, lactate was normal. Patient was not septic, did not look ill, and CTA was negative. Like there, I don't see any evidence of infection or cancer.
I've seen this
Uh,
before where it's like some mysterious, like transient portal venous gas.
Yes. So that's what I thought this was. And that is called idiopathic portovenous gas, like which accounts for apparently 15% of cases. And there's no identifiable underlying cause despite extensive workup. So they have normal lactate. They don't have peritoneal signs. They don't have any acute abdominal symptoms. Hemodynamically stable. There's no sepsis, no shock. They And interestingly, according to open evidence, portal venous gas visible on CT predominantly in the left lobe of the liver. And this kind of, well, at least the initial CT kind of fits the bill. It's more on the left than the right. Well, actually, here, segment 4, I mean, that's still caudate, and then here in segment 2/4. And then the management is just conservative management. I mean, and it's favorable. It and just supportive care, rest, and if they need antibiotics. But is a diagnosis of exclusion. So
Oh, that's
I think
good to
that
know about.
I think that's what this is. But because I don't know, but I didn't see anything else to explain it. And clinically she was fine. Her labs were fine. So
Great. Good for her.
so this is a patient. uh, well, history with health.
There's so much gastric wall thickening.
Yeah, it looks like linitis.
Isn't there a lot of free air also?
Yes. Is it like a gastric ulcer perf or?
The so the ulcer is I saw an ulcer. Maybe it wasn't on this image, but this later became a lot more apparent. This part here, the ulcer here.
Hmm.
This one became a lot worse. And then this, so excellent. So so here's a coronal that kind of shows it a little bit better. So this turned out to be gastric cancer, gastric adenocarcinoma, and this had they called it poorly like cohesive carcinoma with signet ring features. So I looked this up on open evidence. It says poorly cohesive gastric carcinoma with signet feature is a distinct subtype of gastric adenocarcinoma, and it's poor prognosis. Like they have dedifferentiated tumor cells, and the and that creates this like signet ring appearance. And they have very specific like molecular and clinical behaviors, and it's generally, poor prognosis. So I think stomach can be kind of hard because you're like, is it thickened or not thickened? And I'm not, I'm not always clear. And there's plenty of gastric cancers, especially around the cardia, where it would be very hard to call prospectively. So gastric cancer, typically you get more kind of irregular or eccentric thickening, more than 1 centimeter, and the attenuation is more soft tissue rather than low attenuation from edema, like that we see with gastritis. And the, I mean, at the end of the day, they have to do an endoscopy. And then, of course, you want to look for lymph nodes and any other evidence that um, of malignancy like metastasis. And I this kind of makes sense, but apparently the iodine concentration on spectral CT is higher with gastric cancer than things like gastritis because it's a mass, so it's going to take contrast enhancement.
Nelly, can you show the ulcer again? I'm just because
Yeah.
like we always talk about benign versus malignant ulcers,
Uh-huh.
and the way I always explain it to my residents is like a malignant ulcer is like you usually have like heaped up tissue with like an ulceration in there, whereas a benign ulcer like usually it's extending beyond the expected wall of the stomach. This one also like did not really look like it was extending beyond the wall, like it was kind of going into the tumor kind of area. It's just interesting to me that it that caused like a perforation.
I,
But
I
this does definitely look more like a malignant ulcer than a benign one.
this so it the cancer was actually here in the antrum and bo body, and the patient had a uh, subtotal gastrectomy. So here are some of the follow-up after surgery. So had
Oh, so all that other stuff was just gastritis.
Yes, yes. So I think the ulcer is not malignant because that segment of the stomach is still there, and the tumor margins were negative.
Hmm.
So yes, I think it was not a malignant ulcer. Um, and
I wonder if
yeah,
maybe that's how they got, because that's the biggest risk factor for gastric cancer, I think, is H. pylori, like gastritis. So maybe they had just like bad gastritis, led to a gastric cancer, also led to an ulcer.
yeah, and that's actually a really good point because I read that H. pylori gastritis can severe H. pylori gastritis, what you're referring to, mimics gastric cancer. So you can get very severe wall thickening, like it says average of 1.5 to 2 centimeters, and three-quarters of the cases will be reported as suspicious for cancer on CT. That's why endoscopy remains kind of the gold standard. Um, yeah. So, but yeah, did that answer your question?
Yes.
Okay.
Thanks. So this scan does not have any findings, but I learned something new. So anyway, there is one finding. They have severe cardiomegaly.
Cardio.
Yeah. And this patient has like cardiomyopathy, and they're on the list for a heart transplant. The indication for this exam was pre-op liver transplant, which I know sometimes you do heart and liver simultaneous transplants. But it was actually liver transplant for domino transplant. Does anyone know what that is?
Liver transplant for what?
A domino transplant.
No, I don't know.
Okay, well, Nelly, you should know because the first one was done at Mayo Clinic, of course,
I I believe it.
2025.
There's a lot of firsts at Mayo, Rochester, including I heard heart bypass, cardiac bypass. The first cardiac bypass was also done at Mayo,
Oh
Rochester.
yeah, long time ago though. Okay.
Yes.
This was done first time last July. So
Oh,
anyway, basically what happens is I'm going to bring it over here. It's called a HALT D, heart after liver transplant domino. This is Mayo Transplant Medicine last July. So this is a HALT D procedure. And basically it means that what they do is normally they do a heart after a liver transplant, but or at the same time. In this case, they're going to remove this person's liver, give them a new liver, and donate this liver to somebody else. That's the domino part. The reason
what
why
if
is their liver
what
is
does
thought to be pretty normal, but it is sensitized antibody-wise and will promote the rejection of the heart transplant. So they want a new liver in there that is not making antibodies like against the new heart transplant and is not sensitized. And so immunologically, it benefits the patient.
what does domino mean? Or is it just really just
The
like domino?
domino part is that the fact that this liver is going to be actually given to somebody else.
Wow.
Yeah. So they're going to get a new liver, but this liver is not going to be wasted. It's going to be given to somebody else that
Yeah.
is not sensitized to like those particular antibodies. I don't understand all the immunology of it, but anyway. Uh,
And this improves outcome?
uh-huh. Yeah.
Interesting.
I'll send you guys the article, but yeah, this is the HALT D procedure right here.
Like how do you even measure like outcomes? You know?
I don't know.
N of one.
See, the
Anyways, that's very
patient
cool.
receives a liver and then a heart to prevent the likelihood the body will reject the donor heart. At the same time, they donate their own liver to another patient, making each patient a recipient and donor within the same day.
Oh, that's why
Wow.
it is called a domino effect, like series
Yes.
of events. Okay.
Uh-huh. Yep. So anyway, one more thing I wanted to point out is that normally when we do these like liver donor transplants, you guys do living donor.
Yes.
Yeah. So anyway, normally, just some teaching points about that. Like we'll do a multiphasic CT, and the important things are talking about any vascular like anomalies, because they're going to split the liver. If it's a living donor, normally they will give the left lateral sector to a child, or if it's donating to adult, they'll give the right side to the adult. So because of that, you can't have things like crossover abnormalities. You can't have like the right anterior division coming off the left portal vein and also the bile ducts. So the same day we'll also do an MRI with EVIST and look at the bile ducts and make sure there's no like posterior duct crossing over to the left side. So you want to describe all the portal venous anatomy and anomalies, also any hepatic arterial anomalies like right hepatic artery coming from the SMA, left hepatic artery coming from the left gastric like we have here. It depends on what in this particular case, it doesn't matter at all because they're donating the entire liver. It's not like a living donor where you're going to be giving half the liver. But yes, and then the other thing on the living donors is we do volumes just to make sure that if you're removing the left lateral sector, you have enough right lobe left for the patient to not go into liver failure. So those are important things to describe on liver donors. But in this case, we were like, oh, we don't even need to do segmental volumes because it's like we just need to know the whole volume of the liver so that it can match with the new recipient.
That's amazing.
Yeah, it was very cool. My fellow was like, "Yeah, this is for a HALT D," and I'm like, "Okay, explain. Let's learn."
Yeah.
Of
Yeah.
course, it was done at Mayo. But we're gonna do it here now. So,
That's awesome. Wow.
yeah.
Just one thing to add from our prior discussion, we were talking about signet ring cell, and That's the subtype that when that goes to ovary, we call it Krukenberg. Rest all other tumors are just metastasis and not particularly Krukenberg. I was talking about occult malignancy detected with infection. Sorry, I said the species wrong. It's Clostridium septicum, and the other one is Streptococcus bovis. So we have this article from AJR, and they're talking about occult cecal adenocarcinoma, and the patient had this infrarenal aortitis because of this organism. That's how the images look like, and probably some cecal cancer was hiding here. And that's not the standalone case report. I found another one from Curious. And that's the tumor. I don't think they have radiology images here.
Yashant, I have definitely heard about this when leading to aortitis because of like septicemia.
Uh-huh.
I have not heard about it leading to portal venous gas. I can see why it could. I'm just curious, like, are
I
there
think, yeah, I got you. Yeah. No,
Yeah,
no.
like I thought it was like it gets into the bloodstream and then like it implants on aortic thrombi, which it loves to eat on. And then like so if you ever see infectious aortitis with gas, then you should always go look for a colon cancer and these like gas-forming organisms.
Mm-hmm.
But I hadn't seen it with the portal venous gas. Is that also a possibility? Like it seems theoretically like, you know,
Yeah,
even
no, I agree with you. I have not seen either or not read it either as yet. Yeah. That's a very good point you bring out. Yeah.
thank you.
Okay, sure. I will stop share for a minute. And so we have this cardiac CT. I also have CT angio, chest, abdomen, pelvis. So I'll just orient you guys a little here. So this is more like coronal, and this is more like sagittal, and that's the portion of stomach. The patient is lying down, so we have air here, we have fluid in the stomach. And what do we see here?
Whoa, is that a fistula between the stomach and the myocardium?
Pericardium, yes. Yeah, it's difficult to say if it is myo or peri here, but yeah, that's the fistula here. And it's better seen. We did with contrast and make the patient prone.
Wow.
So there was a fistula. So this was gastropericardial fistula.
Well,
And the
there's not a lot of effusion, pericardial effusion, or
yeah,
reactive changes around the
yeah.
heart.
Agreed. And
Impressive use of contrast to get, the proof there.
mhm, mhm. I'll
So it
stop.
looks like the patient's like prone, right?
Patient is prone, yeah.
Mm.
So that's where it is accumulating. I'll stop share for a minute.
Did they have dextrocardia?
I think the patient
No,
slipped.
Oh, sorry.
Yeah, I was thinking the same thing.
just the prone image.
Got it, got it.
And that's how it appears on endoscopy.
Wait, that white stuff, is that pericardial tissue?
That's, yeah, pericardial myocardial tissue, and that's the ulcer or the fistula from the stomach to the pericardium.
Wow, I wonder if it was like beating right in front of them. What did they do?
So they went inside and then they closed this defect with hemostatic clips.
Wow. Okay, this video is making me dizzy.
Sorry.
See, it is beating. That's why it's making you dizzy. It's beating.
That's true. Thank you. That was cool.
This is a patient who presented has a history of breast cancer and skin cancer and multiple prior surgeries. And patient had a CT chest, which showed ascites. No priors are available. And this is what the CT showed because of the ascites that was seen on chest CT. So what do
Lymphangiomatosis.
you,
They look blobby and kind of contained to me,
Yeah, and
not
it's
ascites.
transspatial also. The retroperitoneal one is going in the mesentery. Yeah, lymphangiomas.
And would you just say that and be done?
Yes.
Yes.
How do you differentiate it for something like pseudomyxoma?
It doesn't look like pseudomyxoma. Like pseudomyxoma still follows the peritoneal cavity and scallops organs, but this one is not following the peritoneal cavity. It's like semi-encapsulated or probably encapsulated.
And then
You know what I mean,
this,
Ellie? It's not just like flowing in the peritoneal cavity. Pseudomyxoma will like mimic ascites except for the scalloping part. Like it'll still
uh-huh.
flow through in the peritoneal cavity.
What about this one here?
This is the same patient or a different
Same
patient?
patient.
Maybe now they have chylous ascites from rupture. Oh, well, hold on. Go back up to the liver. Hmm.
Does the patient have lung cysts?
No. So this was 20 years prior.
20 years prior.
Yes.
So I
And
still see
then
some blobby. Are they rupturing? Like, is that
Yeah, I would
produce?
tap this and see if it's chylous.
so this is 20 years prior, and then this is 20 years later.
And no treatment in between.
No treatment in between.
I think some of them had ruptured
Yeah,
Uh, some of what?
the lymphangiomas.
lymphangiomas.
Oh, 20 years prior, you mean?
Yeah.
Um, so yes, excellent. So this was surgically or pathologically proven abdominal cystic lymphangioma. Despite the malignant history, uh, it's a benign congenital malformation of the lymphatic vessels, and you get multilocular cystic lesions within septa and wall. Um, and they like the walls can enhance a little bit, but they're typically multilocular, like we see, and they can arise in the subperitoneal space, retroperitoneum, or mesentery. Uh, 65% are associated with small bowel or its mesentery. So uh, I think other considerations I think that we can think about is like lymphocyte, if the patient is post-op, and then like sometimes patients can have like peritoneal inclusion cyst if they have adhesions from prior surgeries and things like that. So yeah, that they they're no touch lesions, so they don't need any treatment because they're benign, and mo majority remain asymptomatic, and they're found just incidentally. So
Yeah,
and
this is a dramatic example. I think I would have hedged a lot more on that 20 years ago scan. Like I wouldn't have felt as confident as like the way it looks now looks much more typical to me. The 20 years ago one, I might have been like, oh, could be some ruptured cystic neoplasm because it looked like free fluid, but then also like some blobby parts. So I think, yeah, it's a tricky case, but really good. And I have seen cases where, like, basically they have chylous chronic chylous ascites. They have to keep getting paracenteses, and then maybe even like a large catheter. And eventually they might do a lymphangiogram and try to like sclerose off their lymphatic channels. But this one seems to maybe have spontaneously resolved, which is good.
yeah, improving. Yeah.
Okay. This person has ECMO. You can see their ECMO catheter and their IVC. And what caught our eyes was this. I'll put it on bone windows. And I'm going to show you the coronal as well. It was very bright.
Like almost like embolization material, like at the tip of a catheter or something, or
Yeah.
calcifications.
They had no history of embolization, and
But
this
why
is
would you embolize the aorta? That's just like so weird. Um,
and it's not really the aorta.
oh, it's very triangular, kind of
Is it
like
some
a
device?
thing. So do you have sagittal? Where is it relative to the aorta?
So this
Oh,
is
it's
going to be
around it. It's
yeah,
around it.
it's
Oh,
around it, and it seems to be affiliated with the tip of this catheter.
Was it a leak of contrast from the catheter?
Exactly, yeah. So then we were like, what the heck?
oh, it's external. They it poked out.
No. So, okay, I don't have a full answer because no, the patient is completely fine and like basically nobody cared about this finding except for me and my colleague Ayushi. But anyway, we were like freaking out about it. Like we were like, "Oh my God, did it rupture the iliac vein or the IVC or whatever?" So anyway, our theory is that, and you'll notice, okay, first of all, the rest of the scan looks good, right? So most of the contrast that went into this patient went through their circulation and went to their organs. This is not the amount of contrast that we would inject, right? We inject like 100 cc's of contrast. This is not 100 cc's. So our theory is that there was extravasation of injected IV contrast at the very end of the bolus and that it extravasated into some like veins that were like small veins around because the IVC is fine. It's not like it's spreading out anywhere. So we think that extravasated into some veins or possibly like lymphatics that are in this area.
Mm.
And then it was like fine. The patient was like totally hemodynamically stable. We called the ICU. They were like, no, she's fine. And actually, they said they've seen this before in the like chest where like the chest radiologist will suddenly call them and be like, there's contrast in the mediastinum and the patient's totally fine. I went over to IR. They also said that they see this when they inject. And like sometimes it goes into small little like extra veins or lymphatics. And then our other th part of the theory is that it happened because of the ECMO catheter. Like maybe there was kind of an obstruction, like to this high bolus of flow. Maybe
Hmm.
how close the tip of this catheter was, like, the jet of contrast is going here, and then eventually just extravasated into these little like things. So we thought maybe the ECMO contributed to it since we haven't seen this like that much in the, before.
It makes me think about when we do HSGs and you get venous intravasation when you
Hmm.
have marked distension and the fallopian tubes are occluded.
Yeah. Yeah. It was very bizarre. I was like, what? But yeah. So another
Wow.
ECMO related artifact or, kind of incidental thingy. So
Yashant, you could do a education exhibit on this for next year. One of 20 that you'll submit.
Sure.
I'll set the case for you. Okay.
Okay, so this is sorry, I don't know why it's a little bit slow, but you can still see the finding.
What's there in the stomach?
Yes, what's that in the stomach?
Some endophytic.
And then we give you the coronal.
Oh, it's a gist. It's endo-exophytic
Yeah.
Here's the arterial.
ulceration, which is common in gist too.
Yes, exactly. Good job. So this was a gastric gist. They did a wedge resection, did very well. So the gastric, so it just can happen in any of the kind of, it says it rises from the interstitial cells, the caudal, and happens in uh, like adult, mid to late age adults. And 60% occur in the stomach. So over 60% in the stomach, and then second most common site is small intestines, 30%. And then rarely you can have it in the rectum, 3%. Esophagus makes up for less than 1%.
Yeah, and
Uh,
stomach ones have better prognosis, and ulceration is not a aggressive feature.
hmm, good to know. And they're typically big when they present. Over 80% are 5 centimeters or larger. And small tumors that are less than 2 centimeters have very low malignant potential. And like Aarti said, it predominantly presents as an exophytic mass. like 80%. And it can extend into the peritoneal cavity. They have strong arterial phase enhancement unless they have like necrosis, hypo-enhancing central areas. And we can see that in bigger tumors. You get cystic changes, necrosis in, they said 40% of a big gist. Yeah.
Yep. If it's big enough or like in a bad location, they'll shrink it down with Gleevec, and resection is the key. And what you were talking about, the small ones are low risk. There's a nomogram on, like if you would just put in just nomogram online, you
Mm-hmm.
can figure out the rate of recurrence at 5 and 2 years. It's from Memorial Sloan Kettering, and
Mm.
it depends on the site. So gastric is best, and then worse as you go distally. Size, and then mitotic index. And then it'll calculate if it's a low, medium, or high risk gist. And the pathologist will also put that in the path report. I find it helpful because if it's like, a 2 centimeter gastric gist, very low rate of recurrence, whereas like 10 centimeter small bowel, very high rate. So it'll, change your pretest probability when you're reading follow-ups.
That's cool. And apparently there's a practical scoring system for gist identification. So the imaging features that favor GIST over other differential like leiomyomas or schwannomas are age greater than 50, so 50 years and older, irregular margins. If you have unenhanced attenuation less than 43, heterogeneous enhancement, presence of necrosis, absence of lymph nodes. So if you have four or more of those, the sensitivity is 100% with accuracy of 90% for GIST diagnosis.
Wait, this is just for the diagnosis, not for prognosis.
Correct. It's
Got it.
just for identification of GIST.
Interesting.
And there are prognostic features, so like high risk features. So if you have big tumors, lobulated contour, heterogeneous enhancement, necrosis, or cystic degeneration, interrupted mucosa, enlarged feeding or draining vein. Those are high risk features on imaging.
What is this criteria called?
It is called, let me pull it up on open evidence. I'll get back to you.
Okay. I'm going to share my screen.
Okay.
I want to say something for the viewers.
Uh-huh.
For all those who are interested and want to catch up more of this, they can go back to RSNA 2024, and there you will find an amazing exhibit by Aarti and team, and that's also going to come in radiographics as a full paper soon.
Thanks for the plug. Oh, radiographics papers. So enjoyable to write. Okay, so this is my next case.
What's up with the stomach?
Stomach, they are post-op. They just had some surgery, so there's a lot of air around it. Don't worry about the stomach.
There's a catheter in the where is that? Is
What's
it like
that
a fibrin?
psoas hitch? Is that bladder which is hooked up superiorly?
First of all,
It
is
looks
it a catheter?
intravascular. It's intravascular.
Intravascular, is it a catheter?
It looks like it's not meant to be there.
Well, first
Like
of all, is it a catheter or is it metal?
glide wire. There's a guide
Yeah.
wire.
Yes, this is not a
Like,
catheter, this is a wire.
did we forget about a wire or something?
Uh-huh. And then
Oh, and
second,
then lodged into the
and then it
internal
is in the
iliac.
internal iliac. Yeah. So
Ugh.
anyway, this is my second case of this. I don't know if you guys remember, but I showed you a case last year of this. Last year the one it went all the way into the leg and then like just was sitting there. The clue that caught our attention here was why is this thing going into the internal iliac? And then the second clue we were like, wait a second, it's so dense. Like, is this actually a catheter or is it a wire? So we told them to get a chest x-ray because we couldn't see the top of it. And you can see it's going all the way up here. And it was an abandoned IJ wire that was like stuck. And so then IR went and lassoed it out. There they are with their lasso, and they were able to fully pull it out.
Wow.
Yeah. The other one, my other retained wire case, it was actually like part of the wire had gone out of the vein and they could not take out that part of it. So they like removed most of it and then they left the rest inside or like the anyway, this one, the whole thing came out. So
This was the paper that kind of demonstrated imaging features and accuracy or sensitivity based on imaging for GIST. So what they found here, and it's, let me just go down. So they looked at patients with gastric GIST, gastric subepithelial tumors, and they look just gastric tumors or lesions, and they looked to see features that would suggest GIST over other types of gastric lesions. And they found that, again, age 50 years or older, kind of lobulated margins, lower attenuation, and things that we mentioned earlier were predictive of GIST over other gastric lesions.
nice. Thanks. They didn't give a name to the scoring system. I guess just scoring system.
Yeah, I mean, it's a very descriptive name then.
Okay, cool.
So we have this elderly male who comes with bacteremia, and we are trying to find the source for this. So starting with coronal.
What's going on in the left iliac bone?
Yeah.
Posteriorly.
Hip.
Here,
Posteriorly. No.
more
Iliac.
posterior.
Yeah, like there's some that. What is
Yes.
that?
Yeah. So whatever that screw was for the fracture, that's caused this pseudoaneurysm of superior gluteal artery.
That's interesting because it doesn't seem as bright as the blood pool. Oh yeah.
Ooh,
Oh yeah.
So
there's active extravasation too.
that's the screw, and that's the pseudoaneurysm. And the
Hey,
patient.
Nelly, it's interesting that you said active extravasation. Do you actually so?
Oh, I thought I saw something, but maybe is that just a beam hardening artifact from the
Yeah,
screw?
that's no
Can
active
you
extravasation.
can you scroll down a little bit, please? I mean, from the
Sure.
screw down. Okay, all right. No, I don't see it now, but maybe I was getting faked out by the
I
screw.
actually recently had a case of like a large pseudoaneurysm of the common femoral artery, but it kept going. Like it was like a bulbous thing, and then it got narrow, and then a bulbous thing, and then it got narrow, and then it got bigger, and then it went in several different directions. And so my residents were asking me, at what point is this not active extravasation? And so I went over to IR and asked them, and they were like, it doesn't really matter. This is really bad. We got to treat it right now. But you call it a pseudoaneurysm if it seems to be encapsulated, but it's not. It's not like it has a true capsule. It's just like tamponaded off or encapsulated by like your tissue around it.
Yeah. So is active extravasation appropriate then? Is that like a appropriate
Well, this one looks
prescription?
encapsulated to me. That like the one that I had, I can pull it up, but it was going like on and on.
What do you
And
mean it was going on and on? Like you mean like it was getting larger, or it was like
it wasn't
getting
like a round ball. It was like a round ball
lobulated,
and then another one and then a blobby thing that had like multiple, like not a round ball, like
like
multiple.
the morphology changed.
Mm-hmm.
Oh,
So
interesting.
like a string of pearls kind of a thing? Is that
Here,
what you
I'll just pull it up. But anyway, with the IR people were like, at this point, it's kind of semantic because they also had a big hematoma around it too. But I will pull it up right now. How did they treat your patient?
They went inside, IR went inside, and then they embolized one of the feeding vessels.
Okay. Embolized a feeding vessel. Okay. Okay. So this is my companion case, which is like say I just saw this one round thing coming off. I'd say like pseudoaneurysm, right?
Hmm.
Then it went into another one. I would still say that's a pseudoaneurysm. But then it went into like this big thing
Okay.
that see how it's going in like several different directions?
It looks to me like there's the contrast is coming at high pressure and it's just going into the interstitial spaces rather than separate arterial origins.
Well, the artery origin is way back here.
Yeah, like I think it's just dissecting through different spaces that it can dissect through.
Right. So would you call this a pseudoaneurysm? Would you call this? And then look, all this hematoma was new. There's like a hematocrit level. It's dissecting down into the thigh. I guess like my point is, we were debating like pseudoaneurysm, active extrav, and then like Ira's like doesn't matter what you call it.
Yeah, you just have to plug that source,
Yeah,
control that source.
yeah. So yeah, it was big.
This is a patient with GYN malignancy, had THBSO, and there was this lesion here in the sacrum. And this is what it looked like 10 years prior.
The fact that it's 10 years slowly growing,
Schwannoma.
benign thing, like a neurogenic thing, or what are you gonna say, Kater?
Schwannoma. Yeah, I mean neurogenic tumor.
And then, yes, so this is your contrast. It does enhance it here, this little guy here. And then this is what it happened.
So it's destroying the bone now.
Yes.
Hmm.
So this went on to MR, a repeat MR, like 15 years later, and then a biopsy, and this was a sacral neuroendocrine tumor. Sacral neuroendocrine tumor. No neuroendocrine tumor elsewhere. So I just wanted to show this to you. This is extremely, extremely rare, and it can happen in the sacrum or presacral spaces. Patients, most are non-functioning. It's incidental most of the time. And the majority are well differentiated G2, grade 2 tumors, and immunologic profiles resemble the rectal neuroendocrine tumor subtype. And you must exclude kind of metastatic disease from other sites. Patient had a dotatate, and only there's just that site present. So treatment approaches, you want to resect it when it's feasible. And if not feasible for resection, then either PRRT or radiation therapy or targeted therapies.
Wow, neuroendocrine never ceases to surprise.
Hmm. So I heard someone say neurogenic tumor.
Hmm.
On MR, neuroendocrine tumor, they are more vascular. They're more vascular compared to schwannomas. Uh, so, I mean, I think at the end of the day, you probably still need a biopsy like this patient had. But with neuroendocrine tumors, you see avid, kind of more intense arterial phase enhancement. And sometimes you can have necrosis, whereas schwannomas are more heterogeneous enhancement with large central cystic areas. And schwannomas, you get typically smooth, I guess, pressure erosion and expansion of the neuroforamina, whereas neuroendocrine tumor, you saw what happened. There's more erosive changes and aggressive features when it gets to be big. And functional imaging, PET-CT is kind of the gold standard, I guess, to separate those two, and biopsy.
I still think in retrospect, I would not have necessarily brought up a neuroendocrine, but it never ceases to amaze me. Like they could basically be anywhere. Like
Hmm.
your bone, your kidney, like anywhere. Um, okay, well, thanks.
Sigmoid volvulus. No, cecal volvulus. What is some volvulus? Where is that
Okay,
coming?
good. That's the question. Fecal or sigmoid?
Cecal.
Why? Why do you say that?
Because I see the sigmoid all fecal loaded, and then like the classic sign of cecum is like if it becomes big, it goes towards the left. It goes in opposite direction.
Sorry,
Yes.
can you keep scrolling? Yeah.
Yes. So one thing I want to point out here is like this, orientation is going this way, so that's more cecal, whereas sigmoid usually oriented this way. Okay. But the interesting thing is like if this was cecal, why is like the bowel distal to it all fecal loaded and seem obstructed? But I'll just say it was a red herring. This patient has like a chronic history of constipation, and that's why their colon was all. So this was a cecal volvulus. Here is the transition right there from here to here. And then we've got the twist, or like sort of like the volvulus, and then this coming out. Okay. But I wanted to actually show you that the clue was the prior exam. And so when you're not sure what part of bowel something is, when it's obstructed, go to the prior. And this case is really tricky because we've got all this bowel down here, but I will just tell you, this is actually the transverse colon that was extremely redundant.
Wow.
And this was actually the cecum, and then this is actually the ileocecal valve. Okay. So I'll prove it to you, or I'll kind of try to.
There's fat there.
Yeah,
Yeah.
yeah. But also, if you follow the rectum, which is what I like to do with the colon, like follow the rectum backwards, it goes here, it goes here, and then it goes
The
back
left.
down over to here. So that's your left colon. Then it connects over to this transverse colon right here. This is your transverse colon that goes all the way down here. This guy goes back up, goes back. This is your right colon. And this guy goes down and curves into the pelvis, and this is the cecum with the ileocecal valve. So I found this like unless you actually really follow this whole colon, you don't intrinsically think like the cecum is going to be all the way back here. Then knowing how hypermobile that cecum is, and looking at the new exam, now we can see like this whole thing down here is that transverse colon that was like dipping down into the pelvis, right? And then it comes back up, and then it's going here, back down, and then into that very mobile cecum that's now volvulized. And the surgeons did say it does make a difference for their surgical planning, like to know ahead of time, like, do we think it's cecal? Do we think it's sigmoid, et cetera? So in this case, we were able to like look at the prior and then put the pieces together and say, like, we think it's cecal, and it was. Yeah. Even if you have a cecal bascule, we actually had a case recently of like a cecal bascule and it was like mildly dilated. Basically, they said the treatment is a right hemicolectomy. They don't pexy it. And we have another case actually of like a person who has an active, like a very hypermobile cecum that's between their liver and their abdominal wall, and they're having pain. And they said too, they can't pexy it. They have to do a right hemicolectomy. So
Only if it's symptomatic, right?
yes, 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 yes. Yeah. But it doesn't necessarily even have to be completely obstructed. But yes, the like they don't just like detorse it and try to pexy it, especially when it's like hypermobile like this. They just remove the whole colon, or the right colon, yeah.
So there are three types of cecal like obstruction or volvulus we talk about. One is this, the other one is bascule, and what's the third one?
Are you quizzing us or you forgot?
I forgot. No, I'm just
I
seeing
don't
it now.
I don't know.
Okay. Axial type, I forgot what is axial type, then loop type, and cecal bascule. So that's cecal volvulus. And sigmoid volvulus, there's a relatively recent article that I'm going to share soon with you. They describe like, both the loops can be twisted and only one loop can be twisted. And there's some 3 or 4 subtypes of even sigmoid volvulus. So I'm going to share that paper and we can briefly review that next time.
I'm looking up open evidence on the treatment, and like Aarti mentioned, segmental resection is the primary approach. So if it's non-viable or gangrenous, then they do an ileostomy just to let it heal. And they strongly, uh, so like endoscopic reduction should be avoided. Okay, it's only successful in a very small minority of patients. And non-resective procedures like cecopexy, cecostomy, detorsion alone is only limited to like unfit, surgically unfit, or patients with significant morbidity. And like you said, cecal bascule, it follows the same principle as cecal volvulus.
Yeah, we had a case of a cecal bascule that didn't really look obstructed, but it was pretty distended. And
Hmm.
they took them to the OR anyway because they were just like, they're having symptoms. Like most of these bascules have to be resected anyway, even though you don't think it's volvulized, we're still taking them to the OR. So,
That makes sense.
okay, gotta go, guys. See you later. Bye.
Thanks.
Bye.
Bye.
Thank you, guys.